So connective tissue is really diverse. Of all the tissue, of all the 4 primary tissue types, it's really has the widest spectrum of different morphologies. So these are some, and you'll see similar pictures in your book. I tried to find some different ones so you can not only see the same thing, but let's talk about this one first. So again, what's the feature that you see first? You see cell nuclei, right? But they're really far apart from each other, right? What kind of cells are these? There's a nucleus of what kind of cell? Anyone guess? Okay. Most abundant type of connective tissue cell is going to be the lowly fibroblasts. Okay, so they're fibroblasts. And this is an example of one of the 7 types of connective tissue. So this is really simple, simply called loose connective tissue. So kind of a catch-all term, right? It can be found by holding together, providing structural support for many types of structures. So this is a kind of elastic-like tissue under the skin, supportive structures for small organs, hold those organs in place. And what you see in this image, so let's make sure you can identify some of the important features. So you see nuclei that correspond to fibroblasts. You see these thick filaments, and that is collagen, a major abundant structural protein in connective tissue. And then you see these thinner filaments that correspond to elastin. So that's what's there. Okay, another type of connective tissue. Should be pretty easy to identify this one. Very easy. What do you think this is? Wants to be loud. Okay, these are cells that are they are able. The number of this type of cells varies in different parts of the body. The number of these types of cells varies from individual to individual. They are adipose cells. Yes, thank you. And of course, when the body is burning fat for energy, the fat mobilizes out of these droplets. So one huge white cell, the whole cell is taken up with fat droplets, right? Fat mobilizes out of the cell shrinks, and of course you always hear, well, that's why it's so easy to regain weight, because the cell stays there and is able to just regain its previous size. Adipose tissue, very distinctive characteristics. So you see these huge blobs, those are fat cells. This is a bit of epithelial tissue in the middle. So life is not always so black and white. All right, are you surprised to see this cell type in the connective tissue? What is this? It's blood, yes. But blood is, in fact, one of the types of connective tissue. So you can think of it like, okay, the blood is connecting in sort of a communication sense, the parts of the body are talking to each other. In blood, interestingly, now of course the ground substance, the matrix, is a liquid, right? It has many soluble proteins in the plasma, but it doesn't have any protein fibers. So it shows you the diversity of different types of connective tissue. This is quite different from some of the other types of connective tissue that we're going to see. Okay, dense connective tissue, the complement to loose connective tissue. Dense connective tissue, here we're primarily talking about tendons and ligaments, right? And these are mostly consist of collagen fibers. Tendons connecting muscle to bone, and ligaments connecting bone to other bone, providing lots of strength, flexibility, high in collagen. And we might want to say that then going up in terms of strength, cartilage, and bone connective tissue, again, have their own unique morphologies. And again, though, cells, here's cartilage cells, these are chondrocytes, right? Cells pretty distal from each other, right? Surrounded by this matrix, which in this case is sort of gel-like materials. Liquid in blood, jelly type in cartilage, is largely chondroitin sulfate. And then in bone is mineralized between cells. So you see very few cells, and in between them hydroxyapatite, which is a type of calcium phosphate, surrounding all those individual cells. Okay, there are different types of bone. We won't get too much into that. But the defining characteristic again of those connective tissues, all of them, we saw this general situation: cells separated by matrix. And I'll encourage you to go back and take a look at this table in the book, which compares epithelial cells to epithelial tissues to connective tissues in a variety of ways. Again, it talks about different structural ways, components, cell type, arrangement, and so on, by which you might want to compare those. So let's take, in the last 7 minutes, a few minutes to talk about a case study where we're going to look at a clinical situation that covers many of the size scales that we just talked about today. And so on this day, you are part of a crack team of engineering physiologists, and you are shadowing an MD who specializes in rare skin disorders. And so I will just caution you, if you're a sensitive viewer, and I mean that truly, there's only one slide where there is some graphic images, so you may know not to Google for skin disorders. It's very not recommended. But if you can just avert your eyes to the first slide if you have some sensitivity to that. So we're talking about rare skin disorders. And so what kind of tissue are we talking about? The 4 primary types? Epithelial. All right. We're going to talk about protective epithelium. That's right. Okay, so here's the sensitive slide for those of you who don't want to see. Okay, so on this day, a 2-year-old girl presents with painful skin blistering, worsens in the summer months, but has always been present throughout her life, appears on the feet, the hands, the legs, the buttocks. This is a family pedigree, so the trait has appeared in at least 3 generations that the family knows of. The affected family, so the images are the father's hand. The father gets blisters on the hand, as well as the girl's, that's a knee, and the girl's foot, the girl's backside, and so on. So painful skin blistering. So let's remember, we just saw, okay, now you're seeing vector cells and tissues. So we just saw normal skin, protective epithelium. Remember, we have this quantified outer layer. We have underlying epithelial cells in here, and then a variety of other cell types as we go down. Your book actually spends quite some time on the skin, so you can review those if you're interested in other features of skin tissue. So if we take a biopsy from the patient and we look, in fact, this is the situation. So there is separation of the layers, right? And I think that's really clear here. So here is the outer layer separating from the underlying layer, the outer separated and blisters formed here. And say something. And what this is due to is a defect in one of the structural proteins that we talked about a lot today. And in this case, that's keratin. So the patient is making very fragile keratin fibers. So let's look back. So remember, keratin is a type of intermediate filament. And these, in the skin, the major structural cytoskeletal component is the intermediate filaments, and it's keratin. And so here, the presence of abnormal keratin protein bundling and forming those fibers creates fragility, weakness of the epidermal layer. And what's happening is that on any surfaces where there is some friction or some trauma, really normal activities that would be normal for the rest of us, grabbing things, touching things, if you're a 2-year-old falling down because you're not so good at walking and running it, all of those areas, the epidermal layer is easily sheared, easily separating that keratinocyte layer from the underlying layers, and that's where the blisters form. In fact, we can go down now at the protein level and look at this a bit more. Here is 2 subunits of keratin interacting, and what you can see here is that the mutation changes salt bridges between two adjacent fibers, and that changes the structural conformation of the protein, so that's just a little bit bent differently. And we can go down to the genetic level and identify that we're able to sequence the patient's DNA. You probably guessed this is a genetic defect because there's such an obvious family pedigree, right? So, and down at the genetic level, get DNA samples from the parent and as well as the child and the grandparent if that's available. And here we can actually find out where the mutation is. It's a valine mutation at residue 186 here that affects the formation of that salt bridge. And this is in keratin 5. So the K5 is for keratin 5. Remember, there are many types of keratin. How do we know that's what's causing the phenotype? Well, we can go back in the lab and we can say, oh, what if we create that mutation in cells? Can we look at how the intermediate filaments form? And indeed, we can get sort of abnormal intermediate filaments, compare the normal one here, that cause the cells to lose their cell-cell contacts, to kind of shrink and form these sort of clearly aberrant morphologies. And I just wanted to say, so this disease is called epidermolysis. There are multiple types of epidermolysis, and kind of a really sad disease, right? Because in this case it wasn't so severe, but in the much more severe forms, these are patients who really can't. They're very limited in what they can touch, how they can move. They have to be bandaged consistently, so there's mostly palliative care to kind of keep the friction on their skin minimized, right? And often succumb to infections caused by that painful skin blistering, which is now an opportunistic site of infection. But in conclusion, last two slides, I wanted to say that if you go back and now look at the protective epithelium, look at all the other structural proteins that are important in the epithelial layers. So we talked about the outer layer, the surface keratinocytes, then the desmosomes and linking epithelial cells to each other, and as well the cell-cell junctions linking those cells to the basement membrane. Well, in fact, you can find defects in all of these related components, also producing the same phenotypic disease. So in other variations of epidermolysis, so the keratin mutation is keratin 5 is the most predominant, and keratin 14. But you'll also see mutations in desmosome protein, lectin, and in alpha-6 beta-4 integrin proteins, remember are part of adhesions. So with the advent of a molecular basis for this disease as well as genetic testing, all of these different phenotypes, which range from severe to not so, can be grouped together, actually, in a way that would not have been recognized before when they were just examined at the tissue level. So they're all related to cytoskeleton, intermediate function, cell junction defects in the epidermis. That's where we will end for today. Next time we're talking about